Thanks. Thank you.
Okay, so we will get started. Are you recording, Danielle? Just double checking.
Yes.
Okay, fantastic. So good afternoon. My name is Harriet Hudson and I am an OT student at Sydney University, currently on placement at FND Services Australia. I am also joined today by my colleague Danielle Wells and Dr. Catherine Gill, Senior Occupational Therapist, President and Founder of FND Services Australia. As part of FND Awareness Day, we are aiming to increase awareness of functional neurological disorder among our peers and colleagues. This presentation will include information about FND, its impact on the person diagnosed, and the unique role that we as OTs can have in the person's treatment. Before we begin, I would like to acknowledge the traditional custodians of this land. I pay my respects to elders both past, present, and emerging. I am currently on Darug land country, and Danielle is on Darawal country. We encourage you all to share which land you are currently joining us from using the chat box function. So before we begin, we wanted to start with a poll. Have you heard of functional neurological disorder before? So please go to www.menti.com and use the code on the screen 42003859 and answer your question. So I think we will give probably about a minute before we reveal the results.
Can you put the code again in the chat?
Yes, sorry. There we go. Hopefully the code is on the screen.
And this might also be, have you heard of FND before this presentation? Because I know we did send out a bit of a blurb, so that might be interesting to how you consider your responses as well.
Righty, so I suppose that's quite interesting actually that only 13% haven't heard of FND before and that 88% have. The findings are that FND is widely unknown and misunderstood amongst both the medical and general population. So, you know, this is fantastic to see that there's so many of you who have heard of FND before. So I'm just going to stop sharing and go back to the PowerPoint. So whilst it is the second most common reason for a referral to a neurologist after headache or migraine, people with FND spend significant time awaiting diagnosis. They may have symptoms for up to 10 years, and during this time, they go from neurologist to psychiatrist to physiotherapist without receiving appropriate treatment which can delay potential recovery and cause further distress and trauma. So what is FND? Well, functional neurological disorder is a medical condition in which there is a problem in the functioning of the nervous system in how the brain and body sends or receives sensory and motor signals. The example of a computer is often used. So if we think about the hardware of a computer being the structure of the brain and the nervous system, and the software being the connections and functionings between these, FND is a problem in the software, not the hardware. FND does not show up on MRI scans or in pathology, making it very difficult to diagnose. Symptoms vary widely from person to person. They can fluctuate in intensity and sometimes have no observable pattern at all. Symptoms include limb weakness, paralysis, gait disorder, seizures, pain, cognitive issues, fatigue, tremor, abnormal movements, speech, swallowing, and continence issues may also be present. There are no clear predisposing factors or triggers of FND, but it has been found that some people who develop the disease may have experienced trauma or an adverse life event causing psychological distress, push their body to the limits. This may be due to physical injury, surgery, or other medical events, or have had a pre-existing mental or physical health condition such as depression, anxiety, or migraines. Common comorbidities include PTSD, dissociative disorders, EDS, depression, anxiety, or other neurological conditions. Experiences of not having FND symptoms believed, negative interactions in the health sector, and a lack of appropriate treatment are extremely common among this population, as are additional stresses caused by FND, such as subsequent financial stress, loss of employment, loss of social connection, homelessness, or legal battles. Unfortunately, ongoing stresses or adverse experiences such as these lead to poorer prognosis and outcomes overall. So FND is diagnosed by a neurologist using positive neurological signs that are specific to functional neurological disorders. FND is not a diagnosis of exclusion and often presents alongside other neurological conditions, making it very difficult to diagnose. Neurological signs include the Hoover's sign, which is a positive sign for functional leg weakness. So in this test, the weaker leg becomes temporarily stronger when the brain is distracted by engaging the stronger leg in another task. This means that the neural pathways are not damaged and that the brain cannot access the neural pathways during normal movement. The other one is the tremor entrainment test, which is where a tremor frequency changes or ceases when distraction is used. So FND is classified in the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, under somatic and related disorders. Criteria include one or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between the symptom and recognized neurological or medical conditions. The symptom or deficit is not better explained by another medical or mental disorder. And the symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning or warrants medical evaluation. FND slips between systemic gaps between neurology and psychiatry. The symptoms are neurological and physical, yet the disorder is classified under mental health. As stated by Karen Rommelfranger, FND lacks ownership, an orphan to a disciplinary home in medicine, falling in the netherworld of neurology psychiatry abyss. In some cases, people are not even told of their FND diagnosis by medical professionals. They find out through reading their own medical notes or discharge reports. These people can be very confused and have suffered a lot of trauma through their treatment by the healthcare system and medical professionals. So FND is incredibly debilitating. Due to a lack of diagnosis, referrals, and poor treatment, these individuals can literally be housebound for years. It can be a downward spiral of restricted mobility, causing loss of function and independence. Now, we recorded a response of a lady with lived experience to the question, how does FND impact an aspect of your daily life?
And impacts me the most all the time is my mobility. So I was bedridden like pretty much completely for 3 years and 8 months. And through that, the lack of movement, I developed injuries, so it sort of had a domino effect of those injuries are now going to take time to heal. They are taking time to heal. They're kind of actually increasing, the injuries still, even though I'm now up a lot in the wheelchair. Just normal things with mobility that you would usually take for granted. Like if you drop a pair of scissors, you'd expect your foot to jump out of the way to not drop the scissors on your foot, or you'd expect to be able to sort of reach out your arm and grab a cup off the table to drink, or things like that. I miss, and it impacts me the
So as Harriet has mentioned, FND can be quite variable according to the person. Early diagnosis and treatment is essential to improve outcomes, so often people are waiting a long time for this, so that impacts their recovery. After 6 months, the chance of significant recovery is somewhat unlikely, and the condition is likely to be permanent and lifelong. So often it's looking at ways to manage the condition and prevent further functional decline. The key to the start of treatment is beginning with an affirming and positive diagnosis, and just explaining what the condition is and how it can be treated, because people are often quite not as well informed. That can be quite scary for people. So professionals involved in their care can be a speech therapist, a psychologist, a neuropsychiatrist, a neurologist, a physiotherapist, and OTs can often kind of work in conjunction with those potentially, and occupational therapists. So OTs, we have a really unique position in this space. As always, the role will vary depending on the clinical setting, the individual's goals, capacities, and their environment. So we're really thinking about our PEO models here. And we can understand people holistically according to our training, understanding people's mind and body. So if we're thinking about the MOHO, that's one commonly used in practice in people with FND. Because it's a complex, fluctuating condition, it's really, really important to understand a person's values, what motivates them, how they've adapted to their condition according to their capacity, and crucially, what's their occupational identity, what's their narrative story, so you build a picture around that rather than just the complexity of what's going on for them. And as we know, OT is occupation-based intervention, and that's really great because with FND, focusing on symptoms and impairments can often exacerbate the condition. And so when you're doing, engaging those automatic pathways in occupation, that can be more effective over just repetitive practice as well. In terms of intervention, we always have our goal setting, but an important consideration is because FND is fluctuating, it can change quite a bit in how people experience points of exacerbation, remission, even over the day as well. The condition can vary quite a lot. So you really need to be conscious to base goals around being able to do perhaps an occupation over a significant heavy focus on reaching it by a certain point in time as well. As I mentioned, education is quite important given there's not much awareness about it, and helping them understand all the different aspects about how to manage it, the prognosis, and the functional mechanisms surrounding it, because often people will see the MRI is clear, but they're having all these issues that they would expect to associate with something wrong on the MRI. So it's really helping them understand the wiring and things like that. carers need a lot of education, particularly around things like manual handling and support needs, because often people can be quite disabled and carers need that education so they're not burnt out as well, and that's something key to consider as an OT. FND is quite complex, as I've mentioned, so you really need to help self-empower people to understand their symptoms, the triggers and the warning signs, to help them be able to self-manage, work on management strategies and maintain their independence as much as possible. Yep. So people with FND, they really do often experience fatigue, pain and fluctuation really in their capacity. In good times, it can be easy for them to overdo it and then experience an exacerbation afterwards. So this is called like a boom and bust pattern. And so it's really important to work with them to understand the important occupations they value and prioritise, the energy that those might take, and planning the day to maximise functional capacity and incorporate rest. Because FND can often be impacted by stress or press on the nervous system and become overloaded. So you need to, as an OT, consider their occupations and support them in that. So as Harriet mentioned well, there's quite a range of motor symptoms with FND, from tremors to dystonia.
Have we lost Danielle? Oh dear.
Yeah, the sound went.
Are you
She's on
able to
mute.
hear me?
Yeah, I think you went on
Is that
mute.
better?
Yep.
Oh, okay. Sorry about that, guys. Yeah, so as an OT, you may be working in conjunction with a physiotherapist to retrain automatic movement, or just look at postural alignment and weight bearing, so you can support them as well with community access, maybe independence around the home. If someone has functional weakness maybe in their limb, you really don't want to encourage learnt non-use so their condition further degrades. Sometimes distractibility as well, using cognitive techniques, counting backwards, physical or sensory stimulation. So you're directing attention away from a movement or tremor, and that can actually resolve or reduce like the difficulty they're experiencing from that. And we have a bit of a video that Harriet's going to play now, just so you can get a bit of an idea of how this might look.
Oh,
Yeah, so as you can see with that, it's quite remarkable, the difference in her gait and movement. And we can be quite creative as OTs and think about ways that we can support that in occupation in perhaps a better way than having a frisbee on your head while you're walking. And so cognitive symptoms as well, often with the nervous system being under stress, there's often secondary complications as well that impact people's cognition, such as fatigue, pain, sleep and nutrition issues. That can.
I think we've lost you again, Danny.
Yeah.
Are you guys able to hear me now?
Yep. You're cutting
Sorry,
out.
I'm not sure why it's cutting out. Yeah, so you need to look at addressing these factors to be able to support their cognition as well, particularly when you're considering key occupations such as driving. That involves a lot of cognition, and so if people are having difficulty, you need to really consider that with a safety thing as well. However, you also want to maximise independence, as we know. So I remember one client who got quite disoriented in terms of travel and things like that. And yeah, so his wife helped him with a memory aid such as a little app on his phone where he could press it and that would take him to the location via a taxi. So that's supporting his independence as well. So sensory symptoms. There's a lot involved with FND, but people often report difficulty processing and modulating their response to sensory stimuli, particularly, say, with light and sound. I've heard it a number of times, people going to a shopping centre, experiencing, all the different competing light, sound, music, all of those kinds of things. That can really impact their communication, community participation, but also trigger maybe like a functional seizure, which can be quite debilitating and distressing as well. So we know as OTs about sensory kind of systems, and so creating a sensory profile to identify triggers, preferences, and coping strategies as well can be really helpful. Sometimes there might even be a total kind of functional loss of a sense, that might be sight. So it's really key to work closely with the person to promote automatic pathways through grading, give them good education, and have other techniques to increase their conscious awareness of it, because it's not something they're creating, or like you would see or experience that if you could. And so maybe noting when someone may have used their sight but not realised. So I mentioned seizures just recently. And they can look different for different people. That might involve loss of speech, abnormal movements, paralysis and things like that. So you really want to work with people to create some clear plans around perhaps what might trigger a seizure and how people around them can support them in that. And afterwards as well, they might often experience an increased exacerbation of their symptom post-seizure, and that can really impact like dressing, toileting, things like that. They may be walking and have a seizure and then not be able to walk and have those critical self-care capacities. As OTs, we love our aids and equipment, and so that is a part of FND care. They can range from simple cutlery to help with tremors, kettle tippers for weakness, to complex powered wheelchairs and home modifications. They really do need to be considered carefully for people with FND. Early on, you want to be restoring function, but that's not always possible. And so, aids and equipment and things like that might cause reliance, unhelpful movement patterns, which you want to consider in FND, as well as any pain or deconditioning. So using your clinical reasoning for that is really important. However, using an aid might be critical for a person's safety, independence, quality of life, and for their carers as well. So there was a lady that I knew, she had a carer-propelled wheelchair, but her husband was getting quite fatigued in that. Whereas if she could potentially get funded for a powered wheelchair, she might be able to go bushwalking and enjoy an occupation with her family that she hasn't been able to do for such a long time. And OTs were really involved in equipment prescription, so we have a really good space for this. In terms of that as well, with the fluctuation of this, people might have different aids for different days. And so as an OT, you need to train people about when and how to use them, and think about how frequently their difficult days might be. Someone might go, from walking to paralysed and needing a hoist. And so you need to consider that. So given FND is often misunderstood by the medical and wider community, there really is a place for OTs, depending on their capacity, to educate employers on someone's specific FND, how it may impact their engagement and performance at work. So someone might be able to drive to work one day, but they also might not be able to, they might need to go from home the next day or things like that. So it's really looking at what accommodations they might need to support them in that role. Might be rest breaks, accessibility, a graded return to work, all these things we know about as OTs, so using that experience. Often people as well, they might actually have to cease work with FND, and so using their interests, their things like that to support an alternate productive occupation or role. So funding, this is what often Harriet and I and the other students at FND support services, we're looking at NDIS reports. And NDIS is quite complex, it's very tricky and hard to get through. And people with FND and their families often have big financial burdens. So funding is really important but difficult and hard to come by. OTs, as we know, we report on functional capacity, all these things, equipment, aids and things like that. So it's really key to be supporting them in that area. So we have included some resources as well in this slide. So feel free to take a screenshot and we'll have the recording as well. There's a report by our supervisor, Dr. Catherine Gill, that she wrote that has a lot of information about consumer and care experiences of FND. We also just have, FND, there's podcasts by people with FND. So as OTs, we want to understand person first. So just listening to people is really important, good for FND and like really anyone you're treating. And we, of course, have the wonderful FND Australia website, which covers a lot of general information, treatment links, connections, and referrals, as well as training for providers. And then finally, one article by Nicholson et al. Just really does include an overview of key areas of OT involvement and really gold case studies with clinical reasoning surrounding FND. So that's like a really good one to check out. These are just some references that we've used. Always necessary to reference your sources. So that's like our presentation for the moment. We've got a reasonable amount of time for questions, so feel free to kind of put your video on if you're comfortable and ask a question. We'll see how we can navigate answering that. If you'd like to use the chat, feel free to, and I'll try to monitor that as well.
Thanks, Danielle and Harriet. That's a good talk. I'm glad you've learned a lot in your first couple of weeks of placement. Are there any questions from anyone?
Hi. Can you hear me? I was wondering, why is it under the DSM under mental health rather than?
Historically, it's, oh, sorry, do you guys want to answer it?
You go ahead, Kate.
Historically, it's been classified under mental health. So it goes back to historical times like Freudian days when it was called conversion disorder. So because it doesn't have, clear structural damage, etc., it was thought to be a mental health condition. And back in Freudian times, there was a proposal that people were subconsciously converting psychological trauma into a physical response to bring it to light. So it's since been found through very recent research in functional MRIs that that's not exactly what's happening, but it still goes back to that historical time, even going back to Egyptian days. It was called hysteria, and it was assumed to be like a wandering uterus that was wandering around the body, and they had to and remove the uterus from the body to treat it. So it's had a lot of historical myths associated with the condition, which has landed it in the DSM. There is a lot of talk around having it being moved into just the neurological condition of ICD, but that hasn't yet happened. So it's ended up in the DSM, and that does create a lot of problems because people need your physical care, they need to be under neurology, they need to have your neurological reviews, and being classified under the DSM causes a lot of problems, and it also causes a lot of stigma. And then neurologists and physical health care often say, well, this is not us, go to mental health. And mental health go, well, we can't deal with your physical symptoms, go back to neurology. So people end up ping-ponging between the different disciplines. Okay, any other questions?
Hey, I've got a question. Great talk, you guys. I just wanted to know, Danielle, you mentioned that, and you showed us that great video of somebody whose motor symptoms disappeared pretty much when they were focusing on balancing that disc on the head. And you said, we can be pretty creative as OTs and look at ways to use that sort of intervention strategy. I'm just wondering if you've come across any other sort of distractions that you can use, or Kate, I don't know if you can speak to that.
I might have a little crack at answering this,
it.
and Kate will, I'm sure, elaborate with her much wider experience. Another thing as well that can be useful is like sensory stimulation as well, and grounding. So if someone's experienced maybe a bit of dissociation or a trigger or warning signs for like a functional seizure, using those techniques might, as a distraction and grounding, might actually help them not go into a seizure or lessen things as well. So sensory kind of stimulation might be helpful for that. And you can be creative with having, I don't know, I have a little cube here. There might be something as simple as that you could use depending on the person.
Yeah.
Have you heard of the saying the alphabet backwards as well? That's another one.
Yeah, so a lot of cognitive kind of strategies like that. It does depend on the person. So it's often working with a person to find out what works for them. Like some sensory stimuli might be really calming and helpful for the person. Other ones might be overstimulating. So your cognitive tasks, a lot of people find an animal or a pet lying on them. You've got the sensory input of that. You've got your deep pressure. Sometimes having an external person stroke the person can bring people out of a seizure, whereas other people, they're saying like, absolutely do not touch me because being touched is a trauma response for me, so don't do that. So we often work and develop like a seizure management plan to find out when the person's well, what is helpful for you and what is not helpful for you. And it is a bit of trial and error, finding out what works for that person, what doesn't work. The cognitive activities are often very good, but finding out where to set that. So if you've got a very young child, you can't set really high mathematical tasks. And then if you've got someone who's incredibly bright, a basic cognitive task may not work for them because it's not enough distraction. Like sometimes singing can help. Singing's often a good one that people find if they got a voice. Sometimes they might lose their voice if they're in a seizure, but singing does help for some people and even for motor tasks. So it really does depend. And as they mentioned, it's being creative around what's going to work for that person and experimenting.
Hi Kate, it's Jo. I just wanted to ask, and I don't want to go down the biomedical model, but just obviously with the seizures and things like that, are there typical medications that people with FND are on, and do they have side effects that also complicate the neurological presentation of people?
Yeah, so there's no medication directly for functional seizures. So it's not like your epileptic seizures. So around 20% of people will have epileptic seizures and functional seizures. But if they don't have epileptic seizures, the epileptic medication will not work. There are some mood stabilizers that may have an anti-seizure effect. For example, Epilin. So sometimes that can help people. So people may be on some psychiatric medication and it may or may not be helpful. Again, it's a bit around trial and error for people, and a lot of medications have side effects. So yes, that can be an issue. Sometimes people are on medication because they experience significant pain. And again, that has side effects as well. And it's around balancing side effects versus benefit. All right. Any other questions?
I'll ask one more, sorry.
Yep, go for it.
So we talked about the difficulties of NDIS, and are you finding that people that have got a diagnosis of FND, or those that are in the process of trying to ascertain their diagnosis, is there difficulty getting funding because they haven't achieved the diagnosis, or because of the fluctuating condition? What's the
we were getting a lot of success up until about 6 months ago with people getting NDIS. It has got a lot more challenging the last 6 months. NDIS won't accept people until their condition is fully diagnosed, fully treated, and regarded as permanent. So in the first 6 months, it's regarded as an acute condition. So the DSM classification is acute for the first 6 months and persistent after 6 months. So we'd be looking at the person being fully diagnosed and having access to all the relevant treatment. So if they've got physical difficulties, they would have had physiotherapy. If there's mental health comorbidity, they would have had mental health intervention, possibly speech intervention, possibly OT. So have they accessed the relevant treatment to be regarded as fully treated. The fluctuating conditions, certainly NDIS in the past has been okay around the fluctuating conditions. You'll have people who will spend some time being completely paralysed, and then other times their function may improve and they're able to walk and run, and then they might get paralysed and need a wheelchair. So NDIS in the past has been able to meet those needs, but I've certainly noticed the last few months has been a lot harder to get access to NDIS, but people who do have access are getting the equipment, the home modifications and the therapies that help them.
It can often be quite difficult as well, because FND can present, or suspected FND can present with a lot of other neurological conditions like chronic pain or other things, and so sometimes NDIS might come back with needing to be fully treated for other conditions when you're actually applying for funding for FND. So there's a lot of complexity involved in OT reports as well to be able to support their application.
And it's kind of the norm that people don't just have FND. A lot of people are dealing with other health conditions, and your other health conditions are effectively a risk factor for FND. Okay. Anything else people might want to add? Oh, sorry, I didn't. Okay, no problem. Yep. All right. Well, thank you, Danielle and Harriet, for sharing your knowledge on FND and creating awareness on FND Awareness Day. It's been fantastic. And the 4 students that are on placement and they're here today, they're all doing a wonderful job helping people with FND and supporting them to get NDIS. All right.
Thank you, Kate, as well for joining.
No problem.
Yeah, this meeting has been recorded as well. So if you feel like you'd like a recording to send to other colleagues or students who weren't able to come, we'll have that, and you can just send it through to my email and Harriet's email as well.
Awesome. Thanks for that. Okay.
Thank you. Have a
Bye.
Thank you.